thank you very much for joining us tonight for our latest eSeg webinar. So just for information, this webinar is being recorded and I will put the video up on our YouTube channel in a couple of weeks. There is one CPD point available for optometrists and dispensing opticians if you are watching live. Now, there is a Q&A box at the bottom of your screen. If you have any questions throughout the webinar, if you would like to post them in there, and at the end of the webinar, I'll then post the questions to our speaker tonight. This is an interactive webinar, and if you've seen us before, it's a bit more of a quiz. So we will be doing polls throughout the webinar, and hopefully it will work well. Last time we had a polls night, the quiz night, we had a poll that didn't display. If that happens, then I've opened the chat box at the bottom and you can type your answers in there so Mr. Kashani can see your answers. I would just like to welcome today's speaker, Mr. Shahram Kashani. He's an ophthalmic consultant surgeon at East Sussex Healthcare Trust, specialising in the management of complex retinal disorders. He performs intravitreal anti-VEGF injections, steroid implants, anterior and posterior segment laser treatments, as well as high-volume cataract surgeries. He has previously been the clinical lead for East Sussex NHS Trust and is now the head of retinal services and uveitis. Tonight, he will present to us a webinar on challenging cases in clinic. So, Mr. Kashani, I'd like to hand over to you. So thank you very much.
Thank you, Ian, as always. Right, let me share my... Oh, look at that picture, eh? Picture of Ian all those years ago. You still got it, Ian. You've still got it. Right, let me just start this up. Okay. Right, so welcome to the quiz. I think last time the feedback was that it was kind of quite a popular way of presenting info. So if you guys want me to change it for the next visit, let me know, but we'll carry on with this. So these are my financial interest. You've got, most of you have my contact details, my NHS mail. If you have any queries, any questions, anything like that, please do email me. Right, without further ado, case one. So this is an 80-year-old patient who complains of irritation in the left eye. She used to live in South Africa until she was 15, and she moved back to the UK. The left eye has always been amblyopic, and she's recently been to Gambia. So you're looking at the left eye. The area you're looking at is the temporal aspect of the eye, okay? So here comes the question. What seems to be the cause of irritation in the left eye? Is it A, pterygium, B, ringworm, C, exposed sutures from a previous squint op, D, sun-related damage to the conjunctiva? So Ian, hopefully this will work. If you could put up the poll. Da-da-da. And we give we give people 10 seconds. 8, 7, 6, 5, 4, 3. Okay, let's see the answers. Okay, so a fairly even split in the answers. So let's just go through them. So pterygium, some of you thought was pterygium because actually there is evidence to say that wherever if you've been born and grown up somewhere that's very sunny, you're more likely to get pterygium or sun-related damage to the conjunctiva. Some of you thought ringworm because we mentioned, they should be into Africa, but actually, if you look very closely, you've got several kind of, pterygium doesn't normally look very localized like that. First of all, pterygium tends to be nasal, not temporal. And so does penguiculum and sun-related damage. It's unusual to get temporal pterygium. If it was ringworm, then the eye would have probably been a bit more red on the lateral aspect, and it wouldn't have been a whitish looking eye. If you look carefully, these look like exposed sutures from a previous squint. and the hint there was the fact that the patient was amblyopic. But yeah, I could see why people would have thought, oh, is this some sort of weird kind of ringworm under the conjunctiva? So the answer was that. So let's close that up. Let's go to the next question. So we think they're exposed sutures. That's a more magnified view. You can just see that this would have been a suture to manage the lateral rectus. Now that she's got exposed sutures, how would you best manage this patient with the mild irritation? Would you use lubricants? Would you just observe and do nothing? Would you send the patient urgently to hospital eye service, or would there be a routine referral to the adult strabismus service? Okay, yeah, let's have the poll. Should put that timer thing on, shouldn't I? So lubricants, observe, urgent same-day referral to HERS, or routine referral to adult strap service. Okay. Let's have a look at the answers. Okay, so a lot of you went for lubricants. Some went for observation, urgent same-day referral to HERS, and routine. Yeah, so I think I would actually go with the routine referral to adult strap. So you've got exposed sutures there. You've probably got conjunctiva. I mean, there's not going to be a problem giving them lubricants, but you don't want to basically sit and observe this. If they break through or anything like that, it's going to cause patients problems. And you know, the patient is noticing this now and it's causing problems. So I would definitely refer the patient at this point, but it doesn't need to be urgent, it's routine. Okay, good. Well done all. I think most of you got that correctly. So now we're going to go to the second case. Okay. So this is a fundus picture of the right eye. It's a 45-year-old man who's type 1 diabetic, and he had a sudden onset of a blurred spot in the right eye. He's had a recent respiratory illness. Okay, so hopefully that's a bit of a clue there. So you can hopefully see what the most abnormality is: sudden onset, blurred spot in the right eye. What is the cause of the blurred spot? Is it retinal vein occlusion? Is it Valsalva retinopathy? Is it a macroaneurysm? Or is it wet macular degeneration? So what do you think is the most likely cause? And he's put it up. So actually what I'm going to do is, yeah, put the timer on. So 3, 2, 1. Okay, Ian, let's see what people thought. Retrovenation, Valsalva, macroaneurysm. Oh, quite a close one. So, okay, let's talk about this a little bit. So you're quite right. He's 44, he's 45 years old, very unlikely to have wet macular degeneration, okay? And if you look, generally patients with wet macular degeneration, you expect to see something in the macula, you expect to see drusen, you expect to see retinal pigment epithelial change. You can see this gentleman has a pristine kind of macula otherwise. So that makes the macular degeneration very unlikely. Retinal vein occlusion is also not likely because normally you don't just get a very kind of well-defined central spot if you have that. You tend to see venous tortuosity and dilation. You can see widespread hemorrhages. If this was a macular BRVO, I mean, most BRVOs are supratemporal, but if this was a macular BRVO, you would expect to see some changes around here and just some kind of widespread hemorrhaging in this area, not just a very well-defined this. So this can either be a Valsalva retinopathy or a macroaneurysm. So let's talk through that. Well, so if you saw in the history, we said he had respiratory illness, and what you get with the respiratory illness is coughing and straining. So the answer for this is Valsalva retinopathy. There isn't anything you need to particularly do about this because at the moment it's kind of off fovea. And so you could probably just observe that and hope that would go away. Why is it not a macroaneurysm? Well, the macroaneurysm happens within the first 3 divisions of an arteriole. So if you're going to get a macro, then you've got to count to see whether this is within the 3 divisions. It could, I think, if you look, so we've got 1 dividing there, 2 division there, 3 division there, and so this is like division number 4. So macros tend to happen really further up here, supratemporally or infratemporally. They don't tend to happen so close to the fovea, and of course they can leak. So this is not a macro, but sometimes it is very difficult. If this hemorrhage was up here, it's very difficult to see a clear dilation of the retinal artery for it to be a macro. Don't forget, a microaneurysm is a capillary dilation. A macroaneurysm is dilation of an arteriole within the first divisions. This is far too close to the fovea, I think, for it to be a macro. So valsalva retinopathy was the right answer. And moving on, what would be the best mode for treatment? So now we know it's valsalva retinopathy. Could you laser it? Would you use anti-VEGF therapy? Would you just watch? Or could you do an Ozurdex implant? So Ian, shall we? So I'll just move that across a little bit so you see where it is. So would you laser that? Would you use anti-VEGF? Or would you do observation? Or would you do Ozurdex implant? Okay, let's have a look. Good, excellent. 84% are correct. You would indeed observe. You wouldn't laser it because 1, it's very small. 2, it's quite near the fovea, so there's a danger that you could do some damage there. Anti-VEGF and Ozurdex really apply to conditions such as diabetic macular edema, wet macular degeneration, retinal vein occlusion, where there's upregulation of vascular endothelial growth factor. So in valsalva retinopathy, the mechanism is because of the straining, you have the very superficial capillaries on the retina burst. And when that happens, there is blood between vitreous and the retina. So if you did an OCT across that, the hemorrhage will be between the inner retina and the vitreous space. So so the mechanics has nothing to do with VEGF regulation, and in this scenario you would indeed just observe. So I just wanted to show you something else. So this is another patient that we have seen before, one similar. I've lifted these off internet, but we had a similar case like that. So when you've got a big valsalva retinopathy, often you will see a very clear fluid level. You won't see this with any other condition, okay? This is very, very typical of valsalva retinopathy. And in this scenario, if the fovea is kind of covered or being involved, actually, you can see it in this side, you do need to do something, because if you've got blood sitting onto the fovea, that will cause problems if you leave it long term. And what we do is we use YAG laser, but obviously with a retinal lens, and we just laser a couple of holes in the posterior part of the hyaloid face so that the blood will drain into the vitreous cavity, and you will see the blood just go down and the fovea will appear. So I've done it, I think, twice ever in life, so we don't thankfully see it, and it is quite heart-wrenching when you're trying to do this, because you really don't want to get it wrong. So we often aim the laser right at the bottom, which is away from the center of fovea, and just a couple of holes to basically cause a vitreous hemorrhage, instead of the blood being trapped between the retina and the vitreous. So by creating a communication between the blood and the vitreous, the blood will just go into the vitreous instead, and it will clear up the fovea. Okay, good, well done. Most of you got that certainly right. So that was good. Case number 3. Okay, so you've got a referral to hospitalized service for a swollen disc. Patient has no symptoms, but they had pain in the eye yesterday, which was resolved with paracetamol. What is your next step in management if you saw this? Would you do an urgent ESR and CRP? Would you do an MRI scan with contrast? Would you do autofluorescence and ultrasound of the eye? Or would you do fluorescein angiography? I apologize for the spelling of fluorescein. Ian's correctly written it in his, which he very gleefully told me that I had my spelling wrong. So swollen disc, what would you be looking for? Mm-hmm. 4, 3, 2. Okay, Ian, let's have the okay, so most of you would go for fundus autofluorescence and ultrasound, some ESR, some MRI, and some fluorescein angiography. Okay, good. Let's just go through what this is. So hopefully most of you would have seen that this clearly looks very abnormal. The blood vessels are kind of very abnormally divided at the so you've got these kind of what we call trifurcations of the way the blood vessels split rather than the typical kind of quad, you know, 4 divisions that you normally see. When you look at the lid margin, as you can see here, looks fairly okay, and then here it just appears very lumpy and looks very yellow and lumpy. So this patient, hopefully you would agree with me, has disc drusen. Okay, so if the patient has papilledema, the whole disc would be swollen. It wouldn't look yellow and lumpy. Although I must say it's sometimes quite difficult to kind of differentiate the two, especially if the drusen is buried and it's not at the optic nerve head. And normally, if you've got swollen disc, you're not going to have just pain over your eye yesterday. These patients would present often with visual obscurations. They might have had bad headaches, especially waking them in the morning, nausea, vomiting, and all that sort. Because if you've got a swollen disc, you've essentially got raised intracranial pressure, which would give you other symptoms. So ESR and CRP would have been there in order to exclude a GCA type picture. Well, this disc is not swollen, it's optic disc drusen, so that's unlikely. And MRI, urgent MRI would not be useful because MRI is not the best way to look for drusen, and we don't think that this disc is swollen. But the fundus autofluorescence and ultrasound will show up drusen, so that was the correct answer. Fluorescein angiography can be useful to characterize what's happening at the disc, but it's not the mode of choice. So in fact, if you did an ultrasound, you would see this is ultrasound. You could just see an area here which looks hyperreflective. That's what a disc drusen looks like. But most of you actually have fundus autofluorescence if you've got an Optos that can do it for you. So if you go on the autofluorescence mode, you will see kind of bits of it lighting up. And sometimes you can see it incidentally in CT scan, but the other modes are certainly not useful. One of the things that you need to be careful with disc drusen is that patients can develop visual field defects. So it's worth doing a visual field defect. If the drusen is buried, sometimes it can be quite difficult to see kind of what's happening at the nerve head. And if you're worried, then obviously if you think somebody has a swollen nerve, you must refer it in. But this drusen like that hopefully is fairly obvious. And these are kind of fairly non-invasive methods of us diagnosing them. Okay. Right. Okay. Well done again. So we're going to case number 4. Okay. So this is a 45-year-old patient, asymptomatic. Previous picture 1 year ago was completely normal. What is the likely diagnosis? Is it just an artifact? Is it a myelinated nerve fiber? Is it infratemporal branch retinal artery occlusion, or is it retinal commotio? Retinal commotio is a condition which you get as a result of interruption to the blood flow in the retina after trauma. So you just see like a white patch, which then tends to get better on its own. Okay, Ian, can we have the poll? Thank you. So artifact, myelinated nerve fiber, infratemporal BRAO, or retinal commotio. Okay, let's see. Whoa, we both had a bit of a nervous moment. Okay, fine. So 36% thought it was an artifact, and myelin nerve fiber in 19%, BRAO in 17%, and retinal commotion 29. So let me show you the next picture. I will come back to the answer. And then when I saw the patient, that's what I saw. So this, you've got the cornea there, and you've got a white band over here, okay, on the cornea. Maybe I should have put that as a question. So the white band is band keratopathy, okay? So the reason you cannot see properly in the back of the eye is that this is artifact, okay? So always be very careful. Look, when you're trying to capture an image, especially with the with some OCTs like Topcon, etc., you can get your OCT and then it does a fundus picture and you come across something like this. Just think to yourself, could of how you're imaging the back of the eye, and that could easily explain it. Now, let me tell you why it's not those other things. If it was a myelinated nerve fiber, such a large area of myelinated nerve fiber, you would not expect to see any retinal vasculature because the myelin would cover it all. So you won't be able to see anything beneath it. Whereas because this is an artifact, you can still see the retinal vessels below it, okay? Branch retinal artery occlusion would give rise to an edema in the back of the eye, which can appear as pale, but it wouldn't be like this. It wouldn't be so white and then slightly a different shade on that side. And also, this almost looks as if it's something on top of the retinal vessels. So BRAO tends, the edema in BRAO tends to be a lot more subtle, and you've got to catch it early because after a few days or after a week, you will lose the edema in BRAO. And then the other one was retinocommotio, which again is purely on the retina. There's no history of trauma here, and you will, it just doesn't look like this. So the answer was artifact secondary to band keratopathy, and I put that there because somebody, I saw the picture. One of our registrars came and said, "Oh, come have a look at this. What's going on here?" And then I thought it just looked a bit weird. And I looked at the patient's eye, and you could clearly see that there's a big area of band keratopathy. Okay, case number 5. So that one caught a few of you out, but let's see how we go with this one. So 56-year-old myopic choroidal neovascular membrane. Right eye has had multiple Eylea injections, okay? And the patient's had floater in the right eye for a few days. And the patients come to a routine injection clinic, okay? So just take that in. I want you to notice over here, there's like a highlighted area there. Let's go to the next picture. Ah, this is a video, okay? Okay, let me show you that video again. So you're looking, this is the patient when they were seen previous visit. That's the macular OCT. This is them coming in with the floater. And I've put an arrow here because you can just see at the side here that there's like a red patch of increased thickness coming in. So the first picture here is the previous visit. This one is the current visit. The lower one is the current visit. And if you look at your square, on top there, there's nothing there. Here you can see like a red patch, which I've arrowed. And this is the current OCT. Right. Okay. Oh, I think, sorry, we saw that. Should we dilate? Normally we don't, as the decision is mainly based on OCT finding for an injection. Yes or no? So this is a more simple one. So normally when they come to the clinic for injections, we don't normally dilate them. We just look at the OCT to decide whether there's an injection or not. Would you dilate this patient? Yes or no? 1, 2, 3, 4, 5. Okay, let's have the answers. Nice, 97% would dilate. You would. You should always dilate a patient if they have a floater, especially if they're myopic, okay? So what you hopefully noticed was that there was significant subretinal fluid, and the area the subretinal fluid represents is at the top when I showed you on the screen that there was a red patch coming, okay? So what is the most likely diagnosis and management plan? So is this just subretinal fluid and myopic membrane? So you do another ILEA. Is it a detached retina sent to VR team within a week? Is it a detached retina sent to VR that day urgent? Is it subretinal fluid and myopic membrane related, observed as not central? So if you go back to this case, this is the current, so the current OCT is this. Ignore that little cystic space there. It's completely flat in the middle, okay? So what would you do with this patient? Okay, let's see the answer. Nice, okay. Most of you got that right. So there's definitely subretinal fluid. And let me show you the clinical picture of this patient. And you can remove the, close it now. I can close it. So hopefully, so that's the right eye. And hopefully you can see a very large retinal detachment here, superiorly. Fovea is here, okay? So it's very far away from fovea and the fluid is tracking down, okay? So this patient has a retinal detachment. So in a myopic patient, always, if there's a floater, you must dilate, absolutely must dilate. And in this scenario, he's obviously been having injections. So at some point he must have developed a tear. He came, his central vision was fine. He just said he had a bit of a floater. Interestingly, didn't really notice a shadow. And the OCT just looked weird. So this subretinal fluid off center is, let me just stop you where, so you always look to see where your OCT is. Sorry. So when the OCT is going, you know, actually this is far away from the center. This is right at the top of the retina. And myopic CMVM, so a membrane is always in the middle of the macula, not at the top. And this looks not like subretinal fluid. It looks like neurosensory separation from the RPE. Because you can see here, look, this kind of, it's got this kind of wavy appearance rather than a smooth area of subretinal fluid. And that's what made me think something else is going on here. And we dilated him and he had retinal detachment. Now, the question of urgent or not, I know most of you would refer retinal detachments urgently anyway, but if the macula is on, then of course you send the patient immediately. So I couldn't get hold of VR, I just gave them a letter and I say go to Sussex Eye Hospital A&E with that letter, and that was it. If the macula is off, however, but the symptoms are within a week, that still counts as urgent. Okay, anything really more than a week and a half, 2 weeks. So if you know the history is ongoing for 2 weeks, then you know, they wouldn't operate on the patient that day. They tend to kind of schedule them in. So MAC on detachments or just recently MAC off, the VR team will try and operate kind of very quickly. But if the macula has been off for a long time and the evidence of chronic retinal detachment, then they have time and they will basically fix the retina in order to avoid neovascularization and vitreous hemorrhage in that patient. Okay, good. Case 6. So we've got a 78-year-old gentleman who presented with sudden painless loss of vision and shadow infranasally. Okay, so that's the picture there. He's previously had a heart attack 2 years ago and had undergone bypass graft a year. So just have a look at that picture. All right, so he's got infranasal shadow and sudden painless loss of vision. Okay, that's the OCT. So central OCT right across. You could just see some white area here, which hopefully you'll agree is not normal. What does the OCT show? Is it, oh, well, I've told you it's not A. Is it normal? Is there outer retina RPE change? Is it an epiretinal membrane? Or is it retinal edema in the inner retina? So can we have the poll, please? So let me move that across. Is it normal? Is there outer retinal RPE change? Is it epiretinal membrane? Is it retinal edema in the inner retina? Okay, let's have a look at your answers. Nice, yeah. So this is retinal edema in the inner retina. It's not an epiretinal membrane, although there's loss of foveal dip. The epiretinal membrane would normally kind of be present as a hyperreflective line there. There isn't one there really. Outer retina is here, so that's in the wrong place. So this is edema within the inner retina. So we go back to the picture. So that's the picture there you've got, okay? You've got inner retina, edema, and what does the fundo picture show? Do you have a branch retinal artery occlusion with retinal emboli? Is there a central retinal artery occlusion? Is it just normal? Or is there a pigment epithelial detachment superior to fixation? Right, just wait for a few minutes. Okay, let's see what people think. Yeah, good. So we know there's probably an arterial occlusion. But is it branch or is it central? Well, if it was central, then you would probably have expected a cherry red spot. There is a bit of a, you could kind of slightly see a cherry red spot there, can't you? You could just see a slight kind of a red area there. But you would probably see kind of more generalized retinal edema. Maybe these vasculatures all look fairly normal. If I just magnify it for you, can you just see an emboli here? It's a beautiful picture of a retinal emboli bang there with a branch retinal artery occlusion there. You could just see the edema demarcated there, together with the OCT picture that showed evidence of edema. So it's a very nice picture of the emboli with branch retinal artery occlusion as a result. Incidentally, I have put the picture of the OCT after 3 months. So when you look at the OCT picture, you can see that temporally there's correspondence atrophy, which then develops following resolution of the edema. And there is a bit of a cherry red spot there. So for those of you, I'm sure you all know this, but you get the cherry red spot. Actually, the red spot is the normal bit. What happens with in branch or in central retinal artery occlusion, because of the acute edema that happens within the retina, everything swells up. So you see the reflex at the fovea, the blood from choroid reflex at the fovea. Okay, good. So that was BRAO. And actually, what you do with this case, as we're on this, is that you refer them urgently to the TIA or Rapid Access TIA service. They need to see the patients within 2 weeks. They've got positive history being arteriopath with MI and previous bypass. Okay, good. Now, which one of these cases, I think actually this is my last case, you'll be pleased to know, and then we can go for some questions. Which one of these cases would warrant an urgent 2-week referral to hospital eye service? Okay, now let me have a look and see. Okay. Now, if whoever who gets this right can let Ian know, and then you can get a prize or a commendation. Okay, so this is a really tough question. So number 1, so that's picture 1, picture A. So the question is, which one of these cases would warrant an urgent 2-week referral to hospital service. By the way, these are all pictures from patients that we see at HES. So who says we don't see interesting stuff in a district general hospital? So that's A. That's another patient who presented with this picture. Okay. Picture B. I'll show you again. Picture C. This was another very interesting patient we had who presented with that in just a routine clinic. And another one, I saw this patient 2 weeks ago. So let's go through the pictures again. Which one of these would you refer urgently within 2 weeks? So A, B, C, and D. Okay, so here's your answers. A, B, C, D, or none. Just give it another few seconds. And let's go. Okay, so 7 of you got it right. This is pretty impressive. Okay, let's just go through this. And it was a bit of a trick question. I'm sorry. I'm teasing you guys, but we'll go through it and just I'll tell you why. So picture 1. So this is kind of a very unusual form of a myelinated nerve fiber. Normally, myelinated nerve fibers emanate from the disc. And essentially, with myelinated nerve fiber, what happens is that, embryology, long time ago now, if I can recall, the whole of retina is covered with myelin. And as time goes by and the eye matures, the myelin just goes away. So you can essentially have remnants of myelin anywhere within the retina. It doesn't always have to be segmental, or it doesn't always have to be connected to the disc. So this is a typical picture of an area of myelin which never went away. And it is sometimes associated with localized visual field defect, although the patient in this case probably won't be aware of it. You can see that this is very different to that other picture you saw where there was a whole area which just looked non-specifically white, whereas this kind of covers, as I mentioned, the retinal vessel underneath. You can't really see the red underneath. So this is definitely not an urgent referral. This patient had the same picture in the other eye, and you can just see white flecks within the retina, and the blood vessels go over it. And as the other eye looked exactly the same, this looks like some sort of inherited retinal disorder, probably Stargardt's disease. Patients present with, gradual visual loss, etc. So again, inherited retinal disorders, you go through history, etc. But this is not something that you would send urgently. Right, this one is probably the most controversial one. So it looks extremely well-defined lesion. This chap had come from, was it Nigeria or Gambia? I can't remember. But he knew that there was something wrong with his right eye from years ago. He just didn't know what, and he had no information with him. So this is a benign tumor, and it's called an ocular melanocytoma. It's not melanoma, it's a melanocytoma. It can convert into a melanoma, but it's a benign condition, and essentially you observe this patient. These lesions are associated with visual field loss, so this patient will have a superior visual field loss, but you do need regular monitoring to make sure you pick up any conversion into malignancy. And as you can see, it's very well defined and very well-rounded lesion. And finally, this very impressive lesion, patient was 34 years old, long-standing poor vision. Nobody had really diagnosed him, actually. There was no clear inheritance pattern because the patient had been adopted, so he didn't know whether it was any family history. But this is gyrate atrophy. Okay, so you've got very widespread kind of loss of RP and retina, essentially. Very few areas of kind of normal retina stays there. They've got night blindness and light sensitivity. You could just see that there's a very small patch of the macula that's normal. Again, it's long-standing. It's been going on for a very long time. Of course, we want to repeat and see what's happening, but it's not urgent. So the answer actually was none. We didn't refer any of those within 2 weeks. Sorry about that last one. But I thought we all have a bit of fun and games, and as this is virtual, none of you can throw anything at me. So here we go. Right, Ian, let's go to any questions that there might be. Short and sweet, I hope.
Have you stopped sharing?
Oh, sorry.
So just on your quiz at the end there, just to let you know, all the answers are anonymous, so I wouldn't know who answered first, who
Yeah,
got.
but they can tell you who they were if they're on
But I got that right, so I will collect my present off you on
it.
Thursday if that's okay.
Well,
So
and let
yeah.
me guess, Sarah got the other one right.
So we've got a couple of questions for you. So thank you very much for that presentation, Mr. Kashani. That was really interesting, and the polls all worked really well. So I'm quite
Yeah,
relieved.
well done. Yeah, you must be happy.
So if hemorrhage goes into the vitreous, would you risk new vessels?
No, if you're talking about the Valsalva retinopathy case, no, because the problem is you can't have blood sitting against fovea because it's toxic. The iron is toxic to the photoreceptors. So by lasering the inferior part, then the blood will go into the vitreous and it will just settle down, and then it will resolve on its own. So you wouldn't get new vessels. But the problem with that kind of scenario is, of course, you can hit the retina if you're not careful, and you might get a macular burn or a foveal burn, which is why you go for it inferiorly. That's why you wouldn't do it in the first image I showed you, because it was quite a small area. You need to have quite a large area, needs to cover the fovea, and you need to be able to go to the bottom. And you're actually against time a little bit with these ones, because that's why we need to see them urgently, because actually if you leave it for too long, the blood will coagulate, and then it won't go through, then you can't do the laser treatment. So we need to do it acutely for the blood to be released.
Yeah, thank you very much. I'm not sure which slide this question relates to, but hi, wouldn't that be a BRAO? Sure
Maybe,
which slide that was relating to. And also, is a BRAO the same
yeah,
day referral?
absolutely. You refer them same day, and we will refer the patient onto the TIA service immediately. Obviously, if they come on the day and they feel unwell, like they have palpitations or anything like that, then we might want to get them an ECG. If the patient comes in with headaches, then they need ESR CRP. Obviously, you don't let them go until you've done that, because you need to see why there's an arterial occlusion. Is it down to GCAs? Do they have other symptoms? If you can see a clear embolus and it's painless, then you could do a 2-week referral to TIA service. But if they are medically in any way unwell, then you need to get them to see the medics the same day. But if you see it in community, then we need to see it. So often, as I said, if they've got these scotoma things, can be quite funny, because a lot of people come with normal looking macula, but they've got central scotoma, or they've got a very clear defined area that they can't see. And you do the OCT, and the OCT looks normal. But
Mhm.
if you look carefully, you might see like an area of white within the inner retina. And there are certain conditions that cause that picture, BRAO being one of them. Other ones being viral illnesses like AMPI and things like that. They can just give very subtle changes within the macula with a fairly normal looking macula. And by that I mean no fluid, and there's no PEDs, nothing like that. But you've just got to be very careful. And often in cases like that, what you should do is a visual field test. So do a 10-2, or do a 10-2 would be quite good to look for central change, and often that will show something if you're not sure.
Cool. How would we refer to the stroke unit? Is there an email or just sent to the via GP?
I think so what you can do is you write to the GP and say, this patient's got a retinal emboli. Can you please refer to the TIA, Rapid Access TIA service? And that letter needs to go urgent to the GP.
I'm going to come to some more questions, but we did talk at the beginning. And if people could answer in the chat box, do people want another webinar before the end of the year? I can arrange one, but if you could answer in the chat box if you would like another one. Otherwise, I'll wait till next year. But if you could just answer in there now if you want one. I'll go back to the questions. What if the blood is thick? I'm thinking this relates to the.
Yeah, so if the blood is thick, then unfortunately there's nothing you can do because you've lost the chance to. So at that point, you could think about vitrectomy and then removal of the blood. You can't kind of leave blood against the fovea like that for a long time. It's the same thing with if you got high femur, you've got blood against the endothelium, and you can get endothelial kind of staining. So you do need to go in and remove it at that point, surgically rather than laser.
And the next one, BRVO, was it just a typo on the poll page in the queue had BRAO? We'll ignore that one because that's probably a typo in. You had a few typos, so it's probably not me.
No, I don't think there was a BR. Okay, let me just.
BRVO.
There was a case with the. I'll have to have a look. Okay, go to the next one while I'm looking at the. I don't think.
I'll get back because I know who that was, so I'll get back to that person.
Okay.
Yes, please for another webinar. Yes, please for another webinar. Thank you very much indeed. So people are commenting. So I will organise another webinar before the end of the cycle. There were a few people who applied for this webinar by the GOC CPD page that may not be on our WhatsApp group for future webinars. If those people who applied via the GOC, if they want to join our group, if you could email me and I will add you onto our group. I think that is all the questions, but people are wanting another webinar, so I will organise another webinar before the end of the year. Probably not a quick one with posts.
I don't think there was a. No, I don't think there was a typo. So it all seemed okay.
Cool. Brilliant. I think that is all the questions. People are definitely wanting another webinar. What is your email? Somebody's put anonymously. It's the email you joined for the link, irbeseg@gmail.com. We are on Facebook as well, the East Sussex Eye Group, and we're on YouTube as well. So you can always look us up on there and message me, and I will add you to our group.
So the answer to that other one is apparently there was a typo. Somebody's just said to me it said BRAO and then the question said BRVO. So my bad. Sorry. Apologies. Good. I think that's that. So are we
Thank you
going
very
to do
much.
one more in? Well, we've got the peer review in November, haven't we?
So the LOC, East Sussex LOC event day, there will be a peer review by Mr Kashani. We were going to maybe do it on ESEG, but we're going to do the East Sussex LOC day with a peer review. And we are looking at maybe doing peer reviews with our group next year. But I will organise another webinar on here before the end of the year for another point if people need them.
Thank you. Well, see, you're worried about the all the kind of webinars and things, and you were absolutely fine here.
The polls, they
Yeah,
didn't work last time. It worked tonight brilliantly.
you need
So
to give yourself more credit.
thank you very much.
That's all right. Thanks so
Thank
much.
you very much for joining us. Take care all, and we'll see you next time on our next webinar. Thank you very
Thank you.
much.
Bye. Cheers. Bye.
Bye. Bye.